Okay, I think we can get started and folks can continue to come in. So welcome everyone to our ROVER 2.0 head and neck session. This is going to be an hour, so from noon to 1 Pacific time. We'll start off with introductions and just go over some logistics before we jump right into the cases. We have 3 cases to go through today. So I'm Archie Pollan from Stanford. We have Emma Fields here from VCU and Jenna Kahn from Oregon. Will be helping moderate, and then Navjot Sandhu is the coordinator. So we'll be making sure everything runs smoothly. And then today we are very happy to have our 3 panelists. So Beth Beadle from Stanford, Christina Henson from University of Oklahoma, and Nikhil Joshi from Rush University. And they'll be each presenting a head and neck case and leading the discussion on that. So this is meant to be interactive. We'll have poll questions throughout for all the attendees to participate in. And then if there are any questions that you have, just please feel free to put them in the chat box. Make sure it's addressed to panelists as well as attendees so everyone can see the questions and benefit from the answers. The panelists feel free to reply in the chat, or if you think it's a good discussion point, we can also discuss on the Zoom. Anything else, Jenna or Emma, that we need to go over before we start? Nope. Okay, so we'll have Beth Beadle kick it off with the first case.
Thanks to Emma and Jenna and Archie and Navjot for the invitation. Just briefly, I'm Beth Beadle. I'm a professor at Stanford, as Archie mentioned, and I exclusively treat head and neck cases. I think it's important to kind of know where people came from. I was born in Wisconsin. I did undergrad, med school, grad school, and internship at Northwestern, and then residency at MD Anderson, where I stayed on as faculty and then came here. And my research interest is doing cool things with cool people. So if we want to get started in the chat. So the first case is something that we see every day, but I think is more challenging to manage in real life than necessarily in the textbooks. So this is a 32-year-old male who presented with left tongue irritation and some firmness. He described this as annoyance. He had no issues with speech, swallowing, weight loss, or bleeding. He had no past medical history. He was young and healthy. He's a musician and a documentary filmmaker. He's a never smoker, and he has what he considers social alcohol use, so 1 or 2 drinks per night on the weekends. On physical examination, he had no adenopathy. His tongue was midline and there was a left tongue mass, and the biopsy was squamous carcinoma. Can you advance it? So this is a picture of that lesion right now. So you can see there's an ulcerated lesion on the lateral aspect of the tongue, and there's a small area kind of adjacent to that posteriorly as well that looks very superficial, but is in fact also suspicious there. So Dr. Joshi, what do you look for when you're examining the tongue, something like that? What would concern you more or less about this patient?
Yeah, so certainly whether it's submucosal or it's an ulcerative mass on the surface, the extent, for sure, extension, the adjacent floor of mouth, tethering of the actual tongue to the floor of mouth, and then motion, certainly important. Protrusion, does it deviate? Yes or no, any associated cranial nerve palsies that you might notice. Those are typical, and then a more advanced extension to the mandible or adjacent soft tissue, that's also very important.
Right, I think, you know, a lot of us are so used to having imaging by the time we see them as radiation oncologists that oftentimes we go straight to that. But I think especially for these cases, the physical examination tells you a lot of the story. So if there was fixation, extension to the mandible, or nerve involvement, you wouldn't necessarily see that on imaging. And if we can go to the next slide. So the first poll question would be, so in a never smoker 32-year-old patient with a tongue cancer, would you order HPV testing for this case? Dr. Henson, would you?
I would not. It doesn't affect the staging, you know, and as far as we know, it doesn't affect the prognosis for oral tongue cancers in the way that it does for oropharynx. So it's not standard at our institution.
Dr. Joshi?
I completely agree. I think it's oral cavity primary. I wouldn't necessarily order HPV testing.
Okay. Do you see it done?
Yeah, occasionally you'll see it done reflexly. Again, it depends on the location, but sometimes if the pathologist thinks that this was taken from the oropharynx, or if the surgeon specifically requests it, then yes, but we wouldn't necessarily ask for it, at least as a part of clinical management.
Right. I agree. So looking, it looks like we've shared the poll results now. Thanks, Snapshot. So kind of 2/3, 1/3. So 2/3 of people said no, and about a 1/3 said yes. Sort of consistent with that. So I agree with Dr. Joshi and Dr. Henson that I think that sometimes people do it, especially in cases like this, but technically it is not impactful for staging or treatment decisions, and it's not recommended. Next slide. And actually, the college, we can go back to that. The College of American Pathologists came out with a white paper in 2018 that talks about what the role of HPV testing is in oral cavity and head and neck squamous carcinomas, and in fact, malignancies in general. And you can see the recommendation that I've highlighted here is that pathologists should not routinely perform HPV testing on patients with non-oral pharyngeal primary tumors of the head and neck. So again, that's the current recommendations from pathology. This guideline is being revisited, and they just got a committee together to revise it based on new data, but I don't anticipate that will be changing. Next slide. So we did get imaging for this patient, which confirmed what we saw clinically. There was a 2-centimeter lesion involving the left lateral oral tongue. There's no pathologic adenopathy. So the clinical stage would be T1, N0, N0. So I think the next question is there other information that you would like? And so you can see from pathology, there's more than just the diagnosis. So for the squamous carcinomas, you can look and see what else the pathology, even from a biopsy, will give you. So in this case, it was a moderately differentiated keratinizing squamous cell carcinoma. This was reviewed from an outside biopsy. You can see that it says that it extends to a depth of 7 millimeters. And so that was from the biopsy, and it was present at the biopsy aspect. There was no perineural or angiolymphatic or LVSI identified, and it was P16 negative. Again, highlighting that what should be done is not necessarily what is done. So they did do P16 testing. Next slide.
There's a quick question, Dr. Beadle, on the staging, whether it's T1 or T2 based on depth.
Yes. So if you look at back, the date on this is 2017. So that's something to note is that in January of 2018, that staging system changed, and 30%, approximately 30% of cancers were upstaged based on the integration of depth of invasion, and also the use of ECE also in the staging system. So that's something that you have to look to right now to see what is done, and when it was done, to see that it's up to date with the current staging system. So at that time, it was a clinical T2. You can use that depth of invasion, but you're going to want the actual surgery to define what the true stage is. Okay. So plan for treatment. Dr. Joshi or Dr. Henson, would you offer this patient chemoradiation or surgical resection or some combination?
We would definitely recommend primary surgery.
I agree completely. I wouldn't offer definitive chemoradiation.
Okay. So I think I agree. I think there are a lot of discussions about surgery for these cases right now that are ongoing controversies that affect radiation oncology, but in the head and neck surgery world. So if you're doing a primary resection on the lateral aspect of the tongue, how much bulk are they going to take? Do you or do you not need reconstruction? Are you going to do a neck dissection, unilateral or bilateral? And is there a role of sentinel node biopsy? Next. So I agree that I think that the appropriate management for this patient is surgical resection, but there are centers who have long-standing histories of doing definitive chemoradiation for these cases. They are not the normal 70 gray and cisplatin that we do for oropharyngeal cancers, though. They are intense multi-agent chemotherapy, and they tend to be very center specific. most profound and long-lasting experience is probably at the University of Chicago. Their investigators looked more fully to see across the board in a population database what happens for these patients. And you can see here in this study that was published in 2017 that there's significant improvement for patients who were treated with surgical resection. Again, this is not a randomized trial, it's population-based data, but again, highly suggesting that surgical resection is the best option for these patients. Next. So this patient went for a partial glossectomy and a left neck dissection. They elected not to reconstruct because they felt it was going to be a small lateralized resection. You can see the resection specimen here with the ulcerated area laterally there. I think it's really important to go through the operative report by the named attending surgeon to see exactly what was done. You will see any problems that they had at the time of surgery, and there's no way to get that information without reading the report and talking to the surgeon. And you can see that at the time of surgery, they found, as expected, a left lateral oral tongue cancer. They did do frozen section margins, which were negative, and they did a left level 1A, 2B, 2A, 2B, 3, and upper 4 dissection, and they did find a gross node in left level 2 that they had not expected based on imaging. Next slide. So this is a look at the pathology. So you can see, as expected, I think there's a 2-centimeter invasive squamous carcinoma. If you'll remember on the biopsy, they actually called it moderately differentiated, but now on the surgical resection, they felt that it was better described as well differentiated. There was 1 lymph node in level 2 and 1 in level 3 that was positive. So in addition to the gross node they saw at the time of surgery, there was another. And then I think it is best practice now, a lot of the pathologists are doing synoptic tables, but you also have to make certain that what's in the bulk of the pathology matches what's in the bulk in the synoptic table as well. So you can see here that it's a 2-centimeter tumor, well differentiated, margins are negative, there's no LVSI, there is perineural invasion though. You can see there are 2 out of 17 nodes positive, the largest metastatic focus is 0.6 centimeters. One thing to note, if you'll see in this table, is that they actually denote tumor thickness and not depth of invasion. So getting back to the chat question before, that's very important to note that your pathology has to stay up to date on the staging changes as well. So here is just a schematic noting the difference between tumor thickness, which goes from the surface of the mucosa to the deepest part of the lesion at the location of the lesion, versus depth of invasion, which is the deepest part of the lesion compared to the lowest part of the basement membrane in the adjacent normal tissue. So these are different measurements, and you have to know what they are reporting in order to accurately stage patients. So as noted before in the chat, at the time that this patient was treated in like 2017, it was AJCC 7, in which case he would have an N2B. Next. So next question, what additional therapy would you prescribe for this patient? So negative margins, 2 lymph nodes out of 17, resected, no extranodal extension. Would you offer no additional therapy? Would you offer adjuvant radiation to the primary site and ipsilateral neck, the bilateral neck, or chemoradiation to the primary and ipsilateral versus bilateral neck? Dr. Henson, what are your thoughts?
So I typically would do adjuvant radiation to the primary site in the ipsilateral neck, but I know other people who would definitely treat bilateral necks. I don't think that there's an indication for chemo outside of a trial in this patient.
Dr. Joshi?
I agree. Back in 2017, I guess you'd be eligible for 0920, RTOG 0920, but no chemoradiation for sure outside of a clinical trial. The question about ipsilateral radiation is interesting, and I would certainly kind of go down that route, but I guess we'll talk a little bit more about that.
Okay. Would either of you consider uncoupling the primary site and the neck? So if the neck had been negative, but he had PNI in the primary site, would you have treated the primary site and not the neck?
I usually treat the whole operative bed, but I know that this is such a hot point of contention. I don't know if you were at Astro Head and Neck, not this past year, but 2 years prior, and there was a huge debate about it. That was quite interesting.
Yeah, people have a lot of feelings.
Yes.
Dr. Joshi?
Yeah, I agree. It's a contentious issue right now, but I've started actually doing more of this by eliminating the neck if it's a neck dissection with more than 18 lymph nodes. I know it's something we've started looking for that are negative. It's become a metric for surgery. In more marginal patients where really reduction of the toxicity is important. In a 32-year-old, I'd be more comprehensive and kind of go with what the standard is, and I agree with Dr. Henson as well. Kind of treat more comprehensively. But I must admit, I've started doing that more often based on some prelim data.
So you can see the results there. So the majority of people would treat with radiation therapy, and it was split between primary site and ipsilateral neck and primary site and bilateral neck. So I think this is one of the reasons I chose this case, that even though it's a fairly straightforward, just a little tongue cancer, there's a lot of intrinsic differences of opinion in this case. This is a big controversy in the field right now, I think, and it can trace to your sort of radiation oncology training lineage. I think a lot of us were trained that the tongue is a central structure, and if a lesion involves the tongue, it should be treated bilaterally. I think there are some smaller retrospective series showing that in a well-lateralized tumor, there is a low rate of recurrence contralaterally. So some people have begun doing primary site and ipsilateral neck. But for those who believe in bilateral, they will not be happy with that. So, and feel like since there's such rich lymphatics in the tongue and they do drain bilaterally, that you are at risk for both sides. So next. So this patient was treated to 60 gray and 30 fractions. There was no indication for dose escalation above 60 because of negative margins and no extracapsular extension. And you can see the patient was treated to the tumor bed and the ipsilateral neck. Again, since the lymph node, the maximum lymph node implant was 6 millimeters, we really couldn't identify where that was, especially since it was radiographically negative. So the entire area there was treated to 60, 56 to the operated area, and 54 to the unoperated neck on the other side that was also at risk. I like to think about these things in terms of risk. So highest dose to where there was tumor that's resected, intermediate dose to where there was no tumor but also had surgery, and lowest dose to an area that it could go next. Next. Yeah. So I think trying to get done in my allotted time to let Dr. Henson and Dr. Joshi have their cases, I think that there are a lot of challenging aspects of this that we just started discussing. So one is in the evaluation of an oral tongue cancer with no risk factors, should that be considered higher risk because of that? Some would argue that even without the pathologic risk factors for that would dictate chemotherapy in this case, this was a young patient. Perhaps we should throw the book at him in order to try to save him from a cancer that we don't have a clear cause for. There are a lot of surgical questions. Should the patient have a flap? Unilateral versus bilateral dissection. If I feel like I need to treat the bilateral necks with radiation, should they be addressed with surgery instead? And also the role of sentinel lymph node biopsy. As you remember, this patient is a musician, so hand motion and all of that is important. Neck dissection is not a benign surgery. So there is now a trial, NRG HN006, for which this patient would have been eligible, that would have randomized the patient between sentinel lymph node biopsy and neck dissection. The next is staging. Translating AJCC 7 to AJCC 8 is complex, and it's important for us to look at that, make sure our pathologists and our surgeons are aware of the importance of depth of invasion and reporting that and staging it appropriately. And then adjuvant treatment. There is significant and sometimes heated controversy about unilateral versus bilateral neck radiation and uncoupling the neck and the primary site. Coverage of the whole tongue or the flap, the extent of nerve coverage. In the interest of time, I didn't note it, but in fact, we covered cranial nerves 12 and B3 because of the PNI. And then the indications for systemic therapy, RTOG 1216 for high-risk disease, positive margins, and ECE is now accruing, but we should, and And as Dr. Joshi mentioned, this patient would have been eligible for 0920, which was closed at the time of his surgery. So, next. So follow up, the patient finished treatment in August of 2017. I saw him in June. He was NED. We ordered routine carotid ultrasound. Now that he's 3 years out, that showed no hemodynamic plaques or any concerns. His speech swallowing is normal. He's playing his guitar and finished his documentary, and he was seen by head and neck surgery a few months later. I think I see him next week. So that's my case.
That's great. Just one question that popped up by a participant: if the depth of invasion is more than 5 millimeters and more than 18 nodes are negative, the question is, would that force you to treat the neck? And again, I would stick to the standard, like Dr. Beadle talked about, the primary bed as well as the neck nodes. Then it's a case-by-case thing. If this patient was not 32 but 79, for example, would you consider eliminating the neck if you have a good node dissection? I think the answer is variable. I certainly would, in such a case, try to eliminate the neck and just treat the primary bed. But that's not standard, for sure.
Thanks.
Okay, I think I'm up next. So I'm Christina Henson. I am an assistant professor at OU, and I treat mostly head and neck cancer and also a lot of breast cancer here. Happy to be here. So I'm ready for my first slide. Thank you. So you have a 41-year-old female who presents to an outside physician with a 2-year history of a slowly enlarging right-sided neck mass, and she's also reporting some right arm tingling and pain. And that provider gets a CT scan that shows a cystic mass in the right neck that's read tentatively as a branchial cleft cyst. So that provider takes her for a wedge excision of this mass, but frozen sections come back positive for squamous cell carcinoma, and that procedure's aborted in favor of a DL and biopsy. And on the DL, they note a tongue-based lesion with normal overlying mucosa, and finish up the procedure, get a PET scan that shows a hypermetabolic right neck mass in a 1.5 centimeter area of uptake in the base of tongue. So the patient's referred to you for further management with this P16 positive base of tongue cancer. On your exam, she has a approximately 5 centimeter mass in the right neck, and you note that it's fixed. It's not mobile. It seems to be fixed to the SCM. And in chatting with her, you discovered that she has never been a tobacco user. Next slide, please. So this isn't a poll question, but just something to think about is which slide do you think represents tumor from our patient? And the purpose of this slide is just to illustrate the difference in histology for P16 positive versus P16 negative oropharyngeal cancers. So slide B on the right is going to be representative of what's going on with our patient. So you see a lot of hyperchromatic nuclei, you see some necrosis, the cells are packed really tightly in there. You don't see much pink or keratin. And typically these HPV positive cancers are non-keratinizing versus on the left, that's more representative of your typical P16 negative squamous cell carcinoma with keratin pearls and a lot of pink. Next slide, please. So you get a hold of the outside CT scan, and this is what it looks like. So why do you think that this patient might be having right arm pain and tingling? You guys all probably know the answer to this question, which is she's having brachial plexopathy from her tumor. You see that large mass there, just right in the area where the brachial plexus would be emerging between the scalene muscles. And just to refresh your memory, that's comprised of nerve roots from C5 to T1. And the brachial plexus is an organ at risk for our head and neck cancer patients. And normally you're going to want to keep the dose there less than 66 gray. That's not always going to be possible in a patient like this. And if you're not aware, there's a really nice contouring atlas for the brachial plexus from the Red Journal, I think in 2008. So it's a very good reference. Next slide, please. Okay, so poll question based on what I've told you about this patient, what is her group stage? And I would ask Dr. Beadle and Dr. Joshi, when you have a node like that that's compressing the brachial plexus, do you ever de-escalate the dose to just that node? And would it depend on if they're P16 positive or not?
I think it depends on the multidisciplinary evaluation. I would not and see where we're going now. So looking at how infiltrative that lesion was, it's going to be a challenging surgical resection. So sometimes if there are low nodes, in the past we could plan a neck dissection later, so take to a lower dose and then plan for surgical salvage if you've got a good partner, reliable surgeon who won't say later, well, it's smaller, so let's just watch it there. But I do think that our one opportunity to cure this patient is right now. And so it's a challenge to think about de-escalation in this case. Now, there's one controversy that you could consider, which is there has never been shown a survival benefit to induction, but in cases like this, you could consider upfront chemotherapy, not for a survival benefit, but in order to try to get that node to shrink, improve her symptoms, and then more consistently allow you to and safely to de-escalate to try to save the plexus.
Good thought.
I agree. And again, my practice has been to take this patient to 70 gray up front, see how the node responds. And you could even do an adaptive replan and try to come off the plexus. That's another strategy. The induction strategy is also really nice for the reasons Dr. Beadle mentioned. The other thing is I believe the plexus probably can take more than 66 gray. Some of the nasopharyngeal protocols do allow that as a deviation even on protocol. So I think treating the cancer over potential brachial plexus toxicity should be favored, but there are different ways to deal with that, but all very interesting points brought up.
I agree with you both. So interesting mix of answers here. I like it. So this patient's stage 1. She's a T1N1 P16 positive, which per AJCC 8 is a stage 1, but per the previous edition of AJCC 7, she would actually be a stage 4, having multiple nodes in the right neck and one of them being greater than 3 centimeters. Next slide, please. So it's another poll question. What are this patient's treatment options? And I expected the variability to be in the responses here. So Dr. Beadle and Dr. Joshi, what patients are favored for tours at your institutions, or do your institutions do tours regularly?
Yeah, so tours is certainly something that our surgeons like to do, but we like to choose patients who will get away with either bimodality or even unimodality treatment. If they're likely to undergo a trimodality treatment, then that's certainly not something we favor. And that's apart from all the technical considerations that go into tours, like exposure, proximity to the carotid, the hyoid bone. Those are all things to kind of consider. So those are some of the things that we consider for TORS surgery.
I would agree with you.
Yeah, I agree too. So I think I've had the privilege of working with very selective TORS-based surgeons in both my previous practice at MD Anderson and here. So I think the big win as a TORS surgeon is to allow your patients to get radiation alone or nothing at all. And for this patient with that large infiltrative neck mass, we know already that there is going to be high risk for disease left behind there, because it would also require the neck dissection and already would be trimodality therapy. So I think that this isn't an optimal case for that because of the neck.
I definitely agree. I have seen people do tours on patients like this, not at my institution, but I've inherited patients who have had tours for disease like this and come for chemo RT closer to home here. I know that's not the practice for our surgeons here. They're quite selective. So T1 or very small T2 tumors with 1, maybe 2 small lymph nodes in the neck is the most extreme that they're usually willing to get. So we did choose definitive chemo RT for this patient actually on trial. So clinical trial enrollment's never a bad idea. Next slide, please. Okay, so in designing her treatment plan considerations to have in mind are your dose levels. What dose levels are you going to use for your gross disease, for your ipsilateral kind of higher risk neck, for your contralateral neck? Are you going to treat the contralateral neck? And would those, would the answer to that question specifically change if it were a tonsil primary? Those are all things to think about. Next slide, please. So hers being invasive tongue, not a tonsil primary, we treated both sides. Also, given the high burden of disease in the right neck, I think I would have chosen to treat both sides, even if she was a well-lateralized tonsil cancer. So she opted to enroll on HN005, which is a de-escalation trial. She did randomize to the control arm. So she got full dose radiation, actually slightly accelerated at 6 fractions per week with 2 total doses of bolus cisplatin and the following dose levels. Next slide, please. And then these were her doses. So I did not de-escalate the dose to that neck node despite the brachial plexus. And in kind of deciding what to do about this, it's interesting on HN001, which is a nasopharynx trial. It's actually an unacceptable deviation to have brachial plexus dose of greater than, I think, 66 gray. So if it's a smaller than 2 centimeter node, they recommend taking it only to 66 gray versus on HN005, the oropharynx trial, there's not really an unacceptable variation for brachial plexus. So we were able to get away with this for the trial, and the rest of the doses met our goals. Next slide, please. So what is this patient's estimated 5-year overall survival rate?
Dr. Henson, there's a question in the poll about the dose and the fractionation.
Okay.
On the de-escalation trial, why they've chosen to continue the accelerated fractionation.
I don't know if either of you can speak to that. I wasn't there for the conversations on designing the arms for HN005. I know that it's always a active discussion and choosing the control arms, like for HN009 right now, that was a discussion last week. I think it's because it's been shown as effective and you can get away with just 2/3 of the dose of cisplatin.
Yeah, I think I agree with that as well. And the precursor of HN005, HN002, those arms were also accelerated. The other thing is the RTOG NRG always likes to kind of build on studies. So if you look at 1016 and 0129, that's where the standard arm being accelerated probably comes from. I wonder if Dr. Beadle wants to add to that, but I think they've just followed that paradigm that if they did it on 1016 and they did it on 0129, they've carried that forward and extended it to HN005.
Agree. You know, they make the decisions on what the next trials are before the current trials necessarily finish completion. So sometimes you end up betting right, and sometimes you end up betting wrong. But fundamentally, it allows some crosstalk back to other trials, which again is not statistically legal, but just from a kind of ongoing clinical care perspective. So you can talk back to the other things. So for this, it's 70 and 35, so it's 2 gray per day. But then they give it 6 fractions per week, which allows it to be done in 6 weeks. Since the high dose cisplatin is done every 3 weeks, that allows them to get through with 2 doses of high dose cisplatin instead of 3, which would come in the 6.5 weeks or the 7th week if it was continued. So it's only mildly accelerated, and it has been the backbone for a long time. So that's been what's continued.
Sounds like it. Despite all that, it's still not the way that most people do things off study. I know they kind of pulled the audience at NRG last week, and I think I was the only person who said that I commonly do that off trial. So, but it's definitely a good option. And yeah, I'm looking at the chat. Yeah, and I think the biggest way it would affect decision-making for P16 positive patients, that clinical evidence of extranodal extension would be not a good candidate for TORS in my mind. Yeah, I do BID once a week when I do that. Okay, so about half of you chose the right answer on this one, which is about a 95% 5-year overall survival rate, which is why we're looking at treatment de-escalation in this patient population. Next slide, please. So the challenging aspects of this case are that there's kind of multiple options. Theoretically, for how to tackle it, I think there's a best option or a couple of best options, which are standard chemo-RT or a clinical trial, but I've definitely seen other options be chosen in cases like this. The most important thing is a good multidisciplinary collaboration with your surgeons and your medical oncologist. And then decisions regarding treatment de-escalation. Kind of controversial whether to do this off clinical trial. A lot of people do, but really it is important to continue to enroll these patients on clinical trials. So I don't routinely offer true de-escalation off trial. And then there are more nuanced decisions about less official types of de-escalation, like omitting the contralateral neck, in patients where historically you would do bilateral neck radiation, slightly lower elective doses than what were done historically, and things like that. I think that's all of my slides. I'm just looking at the chat. Yeah. Yeah, good questions, guys.
Great. Should we go on to case 3? All right. So I'm Nikhil Joshi. I'm an assistant professor at Rush University Medical Center, kind of new in Chicago. Was recently at the Cleveland Clinic for a couple of years. And I exclusively treat head and neck and skin cancers, melanoma, non-melanoma skin cancers. I did 2 fellowships at the Cleveland Clinic where I moved to before from India, actually. I did my training in India and then I came here and I kind of decided to stay. So very glad to be a part of this and share the stage with Dr. Beadle and Dr. Henson. We could go to the next slide. So we have a 78-year-old gentleman. He had a squamous cell carcinoma of the right tonsil. It was HPV associated. And it wasn't pretty evident what the nodal burden would be on imaging, and underwent TOR surgery, tonsillectomy, with the right-sided neck dissection, level 1B through 4. Ended up being a small primary, 1.1 centimeters, but lots of lymph nodes, 9 out of 12 lymph nodes with ECE, and a positive margin on the primary site as well. Lived pretty far away from where he got surgery, so he got radiation and chemotherapy. I'm not exactly sure why they chose 70 gray. But that's what he received, 70 gray and 35 fractions with 3 cycles of concurrent cisplatin high dose, and was doing pretty okay. This was at another facility. In the meanwhile, after he recovered, he was diagnosed with the left kidney RCC, had a radical nephrectomy. And then towards the end of the year, in November of 2020, he started developing this right-sided headache, some trouble, as he described it, in moving his right tongue. Noticed a little bit of alteration in his speech, some hoarseness and a cough. He came back to see his primary surgeon here. Was noted to have slight deviation of the tongue on protrusion. Other cranial nerves were otherwise okay. His true vocal cords were moving well on the scope exam, and no other mucosal lesions or neck nodes were noted. We can go to the next slide. So, poll question. What is the suspected diagnosis here? Is it a skull-based recurrence of the tonsil cancer, met from another cancer, late toxicity of radiation, or something unrelated? And then what are the next steps? So Dr. Henson and Dr. Beadle, in a case like this, with somebody treated with chemoradiation and comes back with all these symptoms, what are you worried about most, and how do you guys address it?
Definitely my first concern would be for recurrence. So thorough imaging, clinical exam, including a scope, good neck exam.
Yeah, I think all of these are options. So there can be a whole lot of badness, and for a variety of reasons, especially since they can have the toxicity of surgery and the toxicity of radiation. That's a very high dose in the postoperative setting. So there can definitely be soft tissue necrosis. Cranial neuropathies and things like that are rare after radiation, but they are real. So late cranial neuropathies happen in about 5% of patients, or about 5 years later, they keep dropping cranial nerves without a clear evidence of recurrence. So the timeline of this isn't exactly that, but definitely there's a lot of potential toxicity from radiation that we need to own. And he always, wants a cancer patient. I think the number one thing is always to exclude a recurrence that could be attributing some of those symptoms.
Oh, completely agree with both. And yeah, the cranial nerve toxicities, late toxicities, kind of an underappreciated phenomena, but certainly something to look out for. The timeline certainly argues against it, but something to keep in mind. And mets from another cancer as well, not uncommon, especially something like renal cell or even thyroid. You can see these odd sites of metastases. So we have the poll, and most people did point out this is most likely a skull-based recurrence of the tonsil cancer. So like the other speakers alluded to, we would go ahead and evaluate further. Can we have the next slide? So we got a PET CT, and it lit up in the retropharyngeal lymph node space on the right side. And if we could go, there were no other nodes, there were no other distant metastases, and the primary site was doing okay. Can go to the next slide, please. We also got an MRI to further evaluate that area, and again, it shows a right-sided retropharyngeal lymph node and fullness in that area with some submucosal fullness on exam that you can see on the image as well. And that black dot that you see, it kind of encased by the soft tissue, is actually the carotid. Go to the next slide. So I think something that I always like to emphasize is get the previous radiation plan, and that is very telling sometimes and will point things in the right direction. So that's exactly what we did. We have this right-sided RP lymph node, and we got the previous dose from the outside institution, overlaid it, and you can see the green line is the, I believe, the 60 gray isodose line, and you have a purple line that denotes the 70 gray isodose line. As you can see, that RP space was not covered, unfortunately, in the radiation that was done, and that's a recurrence in that area. It's FDG avid, as we noted on the PET CT. But it was actually outside the treated volume, and that's very important to know. It really is going to matter from a treatment standpoint. I'm curious, Dr. Beadle and Dr. Henson, how often do you see these kind of geographic misses from centers that don't really do head and neck radiation often, and how you deal with that?
It's sort of soul crushing. I'll be honest. I see it. It is always a challenge, especially when patients had a fully curable cancer. In this case, it's especially hard because this patient got a huge amount of treatment. They got a surgery, they got 70 gray, and they got 3 cycles of cis, and they still missed. So I think it really highlights the importance of having kind of a good multidisciplinary team, especially for cases like this. But you'll see these happen all the time, unfortunately.
I agree. I don't really have anything to add beyond that. I think that highlights the importance of getting these tumors treated at higher volume centers.
I completely agree, and there is growing evidence to say that there's actually a survival benefit for reasons probably like this, where there's a geographic miss and then it ends up in a non-salvageable or unsalvageable kind of scenario. So we always like to get tissue when possible, but unfortunately it was encasing the carotid, a rather difficult site to biopsy and prove. But there's no other evidence of disease, so we assume that this is an RP nodal recurrence from the original tonsil cancer, which is kind of out of field, but is overlapping with the previous radiation because it's kind of grown down now. Could we go to the next slide, please? So poll question, what are the various salvage options that one can consider? Re-radiation with conventional doses and consider adding chemotherapy, re-radiation with SBRT, surgical resection, or systemic palliative therapy alone, and add palliative radiation maybe as need be. I guess I'll let people vote before I open the discussion for Dr. Beadle and Dr. Henson.
There's also a comment in the chat about protons, which I don't see on here.
That's a great point. I guess we could open that as a discussion point. Dr. Beadle, Dr. Henson, how would you approach this, and then photons versus protons?
So for these patients, like you said, taking into account their prior fields and how long it's been since their prior treatment is really important. So for this patient, say the bulk of her tumor was not irradiated previously, and it sounds like it's been well over a year since that course of treatment. I also consider performance status. Those are probably the biggest things that I consider. So this patient, I would probably want to consider treating pretty aggressively. And when I say that, I mean definitive chemo RT, if possible, up to a dose of 66 or so gray. I think SBRT is an almost as good option if there are geographic issues or if the patient's a little has a little bit less good performance status. Surgical resection is probably the mainstay of treatment for these patients when feasible, but a lot of times it's not. But definitely discussing that as a first option, and then if not a good option without a lot of morbidity, talking about definitive CRT again.
I agree. I think that I would do reirradiation, especially given that it's a geographic miss, the well delineation of that lesion and the time frame. Because someone came up with a nomogram about this that I think Dr. Gucci will talk about in a moment as well. So I think definitely we have a window. If possible, to get any tissue, for instance, an FNA that they can sometimes get transorally, actually, I think it would be good to do testing on this because, you know, especially in cases like this, you want to figure out what you're going to do now and then what you're going to do if it doesn't work. And you can do, there is data on immunotherapy salvage for these patients. And while I don't think it is the appropriate course right now, you'll want to make certain that you've got something ready. Because if your plan right now doesn't work, this patient is going to have very few options next, and I think you want to be ready for that. I think in terms of technique, you want to treat the area that is involved with a small margin. You want to minimize overlap. I typically don't go more than 2 gray per day in these cases, again, due to concern of any overlap for that if I'm doing IMRT or conventional radiation. And while other modalities, such as proton therapy, can definitely give us good dose distributions, there's definitely always pluses and minuses with any technology. So IMRT has the issues with lower, with low dose. SBRT, again, is going to give those high doses. Proton therapy often tends to be quite heterogeneous, and in an area with overlap, those hotspots actually can be very, very worrisome. So I don't think there's a right answer for this. You'd want to compare plans and see what's best for you.
No, great points. And again, going back to the poll, I think the majority actually chose re-radiation with SBRT, and second up was re-radiation with conventional doses, plus minus chemotherapy. A few takers for the other 2 options. We go to the next slide. So yeah, I think SBRT and IMRT were both kind of acceptable options here, and the Cleveland Clinic kind of took the lead on coming up with a large data set among 5 or 6 institutions, and Dr. Ward, Matt Ward, really came up with the nomogram part of it, and this is really good guidance in my mind in how to approach these cases. So the first branch point being how much time from the previous radiation course. This one happened to be less than 2 years, but there's no organ dysfunction as defined by a PEG or a trach. And that puts the patient into class 2, for which a more conventional course of radiation is kind of favored. Certainly here, it being P16 positive and outside the previous radiation field, I did favor IMRT conventional, and we added chemotherapy for sensitization. Just like Dr. Henson had pointed out, the performance status is very important. So he is 79, but otherwise fit. The cisplatin, unfortunately, did cause some permanent renal issues, and his creatinine is kind of hovering around 2. And he's received a pretty high dose of cisplatin to begin with. So for those reasons, we chose to go with conventional radiation. And there's some data, again, coming from this data set, that 66 gray and above is associated with improved outcomes versus lower doses for definitive re-radiation with IMRT. So we go to the next slide, please. So like I mentioned, we chose 66 gray and 33 fractions and an elective dose of 54 gray and 33 fractions with concurrent weekly paclitaxel and carboplatin given the previous cisplatin and the renal dysfunction. We documented the cumulative doses to the spinal cord and brainstem. We utilized the previous radiation plan and did EQD2 calculations, and that's what's tabulated here. It's always good to document that from a medical legal perspective as well as from a treatment-based perspective. And I did allow for some elective volume to cover potential areas of spread. I think there's evidence of subclinical spread along the cranial nerves at the skull base, accounting for some of the more subtle findings on exam and symptoms. I did chase it up into the cavernous sinus, given that this recurrence sat right beneath foramen lacerum and very close to foramen ovale. So that's what we elected to do, and that's kind of the contours you can see if we go up. If we go to the next slide, please. So some challenging aspects of this case. I know we're getting close to time. Recognizing that this is a recurrence and it's in-field versus out-of-field, I think is very important. Certainly informs about the outcome and what kind of treatment one would choose. SBRT versus conventional re-radiation. Here it's P16 positive disease, and it's a recurrence of a P16 positive disease, which is likely still more radiosensitive than others, and long-term side effects are still more of a concern. So choosing a gentler fractionation scheme is probably more prudent, though SBRT, one could argue, could also be utilized. Chemotherapy here added for radiosensitization. It's a matter of controversy whether you would add more chemotherapy on the background of prior chemotherapy, especially for somebody who's 79, and certainly a different chemotherapy from the prior chemotherapy that has been used. A dose composite evaluation documentation, always important, and when possible, try to be more conservative, though sometimes you can't and you just have to push the envelope. But when you can, try to go for the conservative estimates and not allow for forgiveness, especially when it's the brainstem and spinal cord in consideration. Next slide, please. So on treatment, his headache pretty much resolved in the first week of radiation, which is always a good sign and very heartening for the treating physician as well as the patient. The GTV responded very well, as you can see on the cone beam. On the left is the baseline planning scan, and on the right is about 2 weeks in. You can see that the GTV has kind of pulled away, and you can see more air in that GTV space. And this is a case where it's particularly important to watch your cone beams very, very carefully, align to the cord and brainstem, watch any possible motion. Some technology aspects are also pretty important, like having a 6D couch and being able to correct for the roll and pitch to make sure that your doses are aligned to what your planning scan was. So certainly, watch that pretty carefully. Next slide, please. Could we go to the next slide, please?
I believe that was the end.
Oh, that's it. Oh, okay. So that was pretty much it. I thought there was one more slide on follow-up. So patient's doing well, and we'll see how things go in the long run.
Dr. Khan wanted to know if there was anything different you would consider for if you were using stereotactic treatment, like a different type of mask or imaging on treatment.
Oh, that's a great question. So I typically don't. think we have a pretty robust setup. And with the image guidance, I think it's more important that you have a good 6D couch and a good quality KV cone beam CT. That's what I really look for. The mask is pretty much the same.
Wonderful. Looks like a lot of these questions in the chat are getting answered as well. I'll give, if there's anyone that wants to ask one more question before I wrap it up.
To speak to the proton therapy question, I think my answer got kind of lost up above, but especially in cases where the brainstem or the cord might have gotten max doses with the prior course of radiation, and you think you can maybe do a better job with protons, which isn't always the case, but sometimes is, it can be a good option.
Great. Well, thank you to everyone. Thank you to our panelists. Thank you to Nav. Please check out our website. The old lectures will be on there soon. Please email us if you have any questions. You will be getting a survey. We really do look at those and change things based on them. So please fill that out. And lastly, next month, we will be doing logic malignancies. And we look forward to seeing you on March 5th. Thank you.
Thank you guys for organizing.
Thanks, everyone. Thanks for joining.
Thank you all.
Weekend.
Thank you so much. This was great.
Bye.
Bye.
Bye. Bye.